introduce Professor Asper Saman. He was my supervisor during my training in Newcastle upon Tyne as an interventional fellow in cardiology. I still remember he received his professorship at the very first day of my training in Newcastle. So Professor Asper Saman is a clinical professor of cardiology, and he's a senior consultant interventional cardiologist at Freeman Hospitals. He's a director of the cath labs and head of the transcatheter interventions. And his research interests are in the thrombosis and platelet actions, and also acute coronary syndrome. He has published over more than 120 peer-reviewed papers, and he has been a principal investigator for more than 50 clinical trials and chief UK investigator for more than 10 clinical trials. Over to you, Professor.
Okay, thank you for the invitation. The title of my talk today is Antithrombotic Therapy in Acute Coronary Syndromes: When, What and How. And this is largely an article that was written for Education in Heart by my group, and the reference is there at the bottom. So in order to understand the role of dual antiplatelet therapy in acute coronary syndrome, it's important to understand a little bit of the pathophysiology of the disease, which we're all aware of. Of course, it's precipitated by a plaque rupture in an atherosclerotic lesion. And the central component that leads to acute coronary syndromes is thrombus. The hot vessel is in reference to the inflammatory markers that exist, which can propagate the thrombus and leads to slow healing. And of course, distal embolization of thrombus and platelets gives rise to biomarkers of myocardial injury, and the most common that we see, of course, is troponin. So what are the determinants of antithrombotic treatment? We know this as clinicians. We have to weigh up always the ischemic and the bleeding risk. And this is why, when we come to the end of this presentation, we will see that perhaps the biggest changes is in this understanding of weighing the ischemic and bleeding risk and determining the duration of therapy according to that. What this graph, this cartoon shows is that there are many things that we need to consider, not just the acute coronary syndrome presentation or the clinical presentation, but also the patient's characteristics, their comorbidities, their use of concomitant medications, and of course the procedural aspects. Are they going for a percutaneous approach or surgical approach for revascularization? Is it femoral? Is it radial? Are you going to do invasive therapy, or will it be managed conservatively? All of these factors will determine your choice, not just of the agent, but of the dosing and the duration. So this cartoon, taken from the European Society of Cardiology guidelines that came out last year, tells us about the range of drugs that we have as clinicians to manage our patients with acute coronary syndromes. In red are those drugs that are managed parenterally, so they are enoxaparin, fondaparinux, heparin, unfractionated heparin, bivalirudin, which are all given parenterally. In black and bold are the drugs that are available to us that are given orally. So they range from the standard antiplatelets that we're familiar with, clopidogrel, prasugrel, ticagrelor, to the oral anticoagulants, vitamin K antagonists, to the apixaban, edoxaban, and rivaroxaban. So many choices, and what I hope to do is at the end we will have a clear understanding of where the guidelines have taken us. So what about the type of antiplatelets? So the thienopyridines, the choices to us are clopidogrel, ticagrelor, and prasugrel. And of course, the assumption is that aspirin remains the core treatment of your first antiplatelet agents for all of these patients. But the choice we then have is of clopidogrel, ticagrelor, or prasugrel. The biggest change to the ESC guidelines this year was this a recommendation based on the ISAR-REACT-5 study that prasugrel should be considered in preference to ticagrelor for all non-ST ACS patients who proceed to PCI. It was a somewhat controversial change, but nevertheless, this is the guideline. I suspect that in many countries around the world, clopidogrel will remain first choice therapy. And I'll address the issue of when for these thienopyridines. And of course, the greatest wealth of data we have, trial data we have, is for clopidogrel. There are several trials, and I've listed these on the left, ranging from PCI Cure, Armida-5, Acuity, early ACS, to many single center studies. But all of them suggest that clopidogrel, if given too early, has no benefit of pre-treatment, but increases bleeding risk. PCI Cure was a very early study and did show benefit, but remember, in this study, from randomization to PCI was a median time of 10 days, and I'll come back to this point later, is that when we talk about when to give a thienopyridine, the assumption is the patient will have an early invasive therapy, i.e. within 24 hours is the latest recommendation, but within 48 to 72 hours, which is the recommendation in the UK from NICE. What about the other thienopyridines, ticagrelor and prasugrel? When should you give it? So the studies in these areas are somewhat limited to the Plato trial for ticagrelor, the ACOS trial for prasugrel, and then you have a series of registries and meta-analysis that looked at the timing of when to give these drugs. And of course, we have the ISAR-REACT-5, which directly compared ticagrelor to prasugrel. If we go through these trials quickly, the Plato trial, pre-treatment with ticagrelor against in-laboratory was not tested. However, a subgroup analysis showed that pre-treatment was safe, but did not lead to ischemia reduction. The ACOS trial was specifically about pre-treatment, and a half the recommended dose, 30 milligrams, was followed by a second in-laboratory 30 milligram dose compared with 60 milligrams before PCI, but only after the coronary anatomy had been identified in the lab. And what ACOS showed was no benefit of pre-treatment in the ischemic endpoint, but, and this is the big but, there was a 90% increased risk of major and life-threatening bleeding. And what ACOS did was it really put an end to the use of prasugrel as pre-treatment for patients with acute coronary syndrome. Subsequent meta-analysis, the Action Group meta-analysis and SCAR registry and the ISAR-REACT-5 also failed to show significant mortality reduction with pre-treatment. So when we talk about pre-treatment, this is outside of the cath lab. So how has this changed guidelines? The ESC 2020 now recommends that an early invasive strategy within 24 hours is recommended for patients with acute coronary syndrome. We do not administer now routine pre-treatment with a P2Y12 receptor inhibitor if the coronary anatomy is not known. So early invasive management has to be planned if you're going to follow this strategy. In patients with non-ST ACS who cannot undergo an early invasive strategy, pre-treatment with a P2Y12 receptor inhibitor may be considered depending on bleeding risk. So just to give you an example, in the UK, our mean transfer times are around 4 days. So in the UK, we do give pre-treatment, typically with ticagrelor or clopidogrel, but that's because our transfer times from admission to cath lab is around 4 days. So when the take-home message, overall, in the setting of early invasive therapy within 24 hours for ESC, the evidence supporting early treatment with thienopyridines is limited. The balance of evidence suggests no ischemic benefit, but increased bleeding events. Therefore, the recommendation is to start thienopyridine therapy in the cath lab once the anatomy is known and the decision has been made to proceed to PCI. What about intravenous antiplatelets? Well, the message here is relatively clearer in that one would have thought that the failure of pre-treatment with oral thienopyridines would be surprising given the role of platelets that I outlined in the pathophysiology at the beginning of this talk. And people then ask, well, is this because we're giving it orally, and would parenteral therapy be better? However, all the trials, and there's numerous trials listed here in this slide, there is no evidence for ischemic benefits of routine upstream GPI. And certainly there is limited, very, very limited data where intravenous therapy was given with ticagrelor or prasugrel on board. Cangrelor lacks evidence in the presence of prasugrel or ticagrelor. So, in summary, the use of intravenous agents, antiplatelet agents for pre-treatment is not recommended and is limited to bailout situations only. What about anticoagulants? So it is recommended that parenteral anticoagulation for all patients at the time of diagnosis, and particularly during revascularization, is given based on ischemic bleeding risk. Heparin is cheap, it's cost effective, and it is effective, and those are the doses that we give. If there is only medical treatment, that you've made a decision not to give invasive treatment, or there are delays in transferring the patient to a PCI within the required time frame, i.e. within 24 hours according to the ESC, then fondaparinux is the recommended anticoagulant, and in such cases a single bolus of unfractionated heparin must be given at the time of PCI. Once the revascularization procedure is finished, the anticoagulation must be stopped immediately. Perhaps the biggest change over the last 2 to 3 years, as evidence has come out, is about the duration of dual antiplatelet therapy, and I've titled this slide, How Long? And if you look to the right of this slide, the first thing to do when you talk about duration is to identify the patient and to classify them on the basis of bleeding risk. Low, high, or very high to the right. If the patient is very high risk, then the only thienopyridine you consider is clopidogrel, and that should be for a month, after which you can stop the aspirin and continue clopidogrel dependent on bleeding risk. If the bleeding risk is high, also it's aspirin and clopidogrel for up to 3 months, and then you can stop the clopidogrel and continue aspirin. If the bleeding risk is low, this is where there is patient choice, and it becomes confusing, but this graph, this chart, tells you what the options you have. So based on the global leaders, you have the option of dual antiplatelet therapy with aspirin and ticagrelor for 3 months, and then ticagrelor as sole therapy up to 12 months. You also have the option, as the current recommendation says, is that based on ISAR React 5, that you can give aspirin and prasugrel, which is now recommended by the ESC. You also have the option of giving ticagrelor or clopidogrel for up to 12 months. The big change is that after 12 months in certain groups of patients at high risk for ischemic events, and you can base this based on the Pegasus trial, you can now extend therapy for beyond 1 year, so anything up to 3 years, and that can be with rivaroxaban low dose based on the COMPASS study, 2.5 milligrams BD, or it can be with ticagrelor based on the Pegasus study, or the ESC says you can extend it with prasugrel or clopidogrel also beyond 12 months. So this is where the biggest change has been, is on the duration beyond 12 months. But the key thing, as the early slide said, is identify your patient in terms of bleeding risk before you decide which agent and how long. So how long? In high bleeding risk, Leaders 3 and Onyx 1 trial confirms the safety of 1 month DAPT. So with the biosensors and the Resolute Onyx, it's safe to give 1 month of therapy. In high ischemic low bleeding risk, you can extend DAPT based on the Pegasus trial with ticagrelor 60 milligrams BD, and the COMPASS study demonstrates the benefit of long-term low-dose rivaroxaban for high-risk patients, particularly those with peripheral vascular disease and diabetes. The Twilight study showed the safety of ticagrelor monotherapy, and this is perhaps where the direction of travel is. We're now looking at monotherapy as being safe, at least after 3 months of dual antiplatelet therapy with ticagrelor and aspirin. And in your low ischemic high bleeding risk patients, perhaps monotherapy, based on the Twilight study, may be safe with ticagrelor. So if we go back to the recommendation, how long you can now add a second antithrombotic agent to aspirin for extended long-term prevention, and this has a 2A recommendation for the ESC. Adding a second antithrombotic agent to aspirin for long-term secondary prevention can also be considered in those with moderately increased risk of ischemic events, 2BA. And in ACS patients with no prior stroke or transient ischemic attack who are at high ischemic risk, you now have the option of adding low-dose rivaroxaban 2.5 milligrams BD to your aspirin and clopidogrel after discontinuing of parenteral anticoagulation. So in low bleeding, high ischemic risk, you can now consider triple therapy. Perhaps the biggest or the newest agent with the biggest change that's come on the scene is cangrelor. And this is an expensive intravenous agent that we have used only in a very limited fashion over the last couple of years. And the recommendation for the use of this parenteral intravenous very short-acting thienopyridine is that it is best reserved in patients who present with out-of-hospital arrest or cardiogenic shock and are unable to be given an oral agent either crushed or through an NG tube. So if you have patients who present with out-of-hospital arrest or with cardiogenic shock and are unable to swallow and they don't have an NG tube, then the ESC recommendation is that you start with aspirin. You can give it either orally or intravenously. And then you have a choice of the P2Y12 inhibitors. The simplest is to give IV cangrelor. You also have the option, as this graph shows here, of ticagrelor or prasugrel that's crushed via a nasogastric tube, and clopidogrel if the patient is deemed to be high bleeding risk. Once you have given this, you can then give parenteral antithrombotic therapy to cover the period before onset of oral thienopyridine, and that typically is tirofiban that we can give. But using cangrelor offsets all of this issue of putting a nasogastric tube in. So this is where cangrelor is limited. Obviously use the transradial approach and you give unfractionated heparin at the time of the procedure. So in summary, if we look at the oral agents, what? The ESC recommendation is that the oral thienopyridine of choice is prasugrel and the intravenous agent is for bailout only. When? The timing of oral thienopyridine for acute coronary syndrome is once the coronary anatomy has been defined. So it's in the cath lab when you have made the decision to proceed to PCI. The one exception perhaps is in ST elevation myocardial infarction, where we give thienopyridines before coronary angiography, but the Atlantic study showed that there was no clinical benefit, although there was some benefit in early ST resolution and angiographic flow. How long? This is perhaps the biggest change, where the duration can now be from 1 month in your high bleeding risk to several years based on high ischemic risk. If we go to the parenteral agents, what? So fondaparinux, if you're going to treat medically, and certainly before they go to the cath lab. Glycoprotein inhibitors are now only limited for bailout situations. When? So before coronary angiography, you give fondaparinux. In the cath lab, you give unfractionated heparin. For parenteral anticoagulants, you stop immediately after PCI. So to conclude, ladies and gentlemen, based on the pathophysiology of acute coronary syndrome, antithrombotics are essential core therapy for patients who present with an acute coronary syndrome based on the pathophysiology of a ruptured plaque that leads to thrombus formation and subsequent embolization. We are clear that thienopyridines need to start only after coronary anatomy is known. And this is with the proviso that the patient is brought to the cath lab within 24 hours of symptom onset. If in your system the patient transfer time is longer, then you may consider starting a thienopyridine prior to the cath lab. The role of antiplatelets, intravenous antiplatelets now is very clear. They're limited to bailout situations only. Perhaps the biggest change to dual antiplatelet therapy is the recommendation for duration. Whereas before it was around 12 months, 6 months, this now ranges from 1 month to 3 years or longer, and it is dependent on individual patient risk, a balance between ischemic and bleeding risk. Thank you for your attention.
Thank you very much, Professor Saman, for your well-illustrated lecture on antithrombotic therapy in acute coronary syndrome. I would like to invite Dr. Tanya Pereira to introduce our next.
Thank you,